Is Dr. Chatterjee a case of profound vasoplegia post-CABG?
Great. I'd like to thank Dr. Carr, Grigorich, and Jermaine for the privilege of the invitation. Today we'll go through our thought process in a case of profound vasoplegia. So we have a 63-year-old man, comes in with a non-STEMI, some hypertension, diabetes, CKD3 with a creatinine of 1.8, 40% ventricular function. He's had some Hodgkin's mediastinal radiation, some episodes of pericarditis in the past. He was on lisinopril, which we stopped 48 hours before, and some standard medications. So he comes in with multivessel coronary disease. He's referred for CABG, low risk on his STS score. So 4-vessel CABG, the operation takes a long time because of the adhesions and the pericarditis, long clamp time, long bypass run, gets a couple of units of bloods. We come off pump, maps are in the 50, 7-liter cardiac output. Smart anesthesiologists are up there. They try norepi and vaso, not working. They initiate epi, phenylephrine, dopamine, still not working. They start pulling out methylene blue, hydrocortisone, still not working. So now we're faced with this dilemma. What do we do now? So post-cardiotomy vasoplegic shock is characterized by a low mean arterial pressure, a high cardiac output, a low systemic vascular resistance, and the need for quote-unquote high-dose vasopressors. Because of the lack of a consensus definition, the incidence and the mortality ranges very widely in the published literature. Now, the pathophysiology behind this is that in the physiological adaptive state, our body preserves our blood pressure by constricting and dilating the resistance vessels. In the pathologic state, we lose this and we get systemic vasodilation. It's well recognized that in post-cardiotomy, the primary risk factors for the development of vasoplegia are long operations, long clamp time, long pump run, a lot of transfusions, people who've had previous surgery and renal failure. So how do we approach this from a vasopressor standpoint? There are a number of randomized trials. The SOAP2 trial taught us that norepi was better than dopamine because it was less arrhythmogenic. The VAST trial said start vasopressin earlier rather than escalate to high-dose norepinephrine. The VANISH trial said there might be a benefit to vasopressin in less renal replacement therapy, and the VANCS trial, which is the only randomized trial dedicated just to cardiac surgery that compared monotherapy norepinephrine to vasopressin, showed that despite the mortality being similar, there was a clear benefit to vasopressin with respect to less atrial fibrillation and need for dialysis. So, systematic review, this is predominantly in sepsis, and that's where we glean and extrapolate a lot of our literature. Over 3,000 patients comparing norepinephrine monotherapy to combination therapy. This came up with these results. So basically, in terms of mortality, maybe a little bit of a benefit with using combination therapy. Same with atrial fibrillation. No real difference in renal replacement therapy, and perhaps a small benefit with just using one drug in terms of limb ischemia. Now, what is the benefit of vasopressin? So this is an interesting study, off-pump surgery. They all got loaded with milrinone. And you can see in the norepinephrine group, when you compare the PVR to SVR ratio, norepinephrine really has no effect on PVR, whereas vasopressin reduces PVR. And in the bottom panel, you can see a clear benefit to vasopressin in terms of reducing pulmonary vascular resistance, which is why it's our preferred drug in cases of right ventricular dysfunction. And I agree with some of my Penn colleagues here that it's a vasopressin in the perioperative state is a gift that keeps on giving. Now, vasopressin, what about responders versus non-responders? This study out of the Cleveland Clinic tells us about half the patients are actually vasopressin responders, and as you can imagine, the responders do better with respect to preserving the mean arterial pressure, lower lactates, and coming off of vasopressors more quickly. Now, does timing matter? Again, this is a large group in septic shock. What they found here is that the earlier you started vasopressin, the better it was for survival. The sooner you started vasopressin, the lactates were lower, and the overall mortality was lower. So there's a clear benefit to that. Interesting pathologic speculation about what is the role of vasopressin in post-cardiac surgery. So this is an interesting study that looked at the circulating vasopressin levels after cardiac surgery, and you can see here that there's a clear reduction in the post-cardiotomy patients who developed vasoplegic shock compared to their normotensive counterparts. So this happened somewhere between day 1 and day 2. So perhaps there's a relative vasopressin deficiency after cardiac surgery, which might suggest a benefit to using it sooner. Epinephrine, number of different trials, no real difference in the use of epinephrine. And yes, as surgeons, we love using epi right off the bat. Now, the renin-angiotensin-aldosterone pathway. So we're all familiar that in states of shock and post-cardiotomy as well, with damage to the lung, there's a reduction in the ACE enzyme activity, which leads to an increase in renin and reduction in angiotensin II. So we look at what's the role for angiotensin II. This is not a new drug. It's been around for over 50 to, even when Dr. Zwischenberger was first starting out, this drug was still being used. And so where they looked here in the ATHOS-3 trial, so the New England Journal of Medicine, this was published a few years back looking at angiotensin II, predominantly a sepsis trial here. And what you see here is that in the angiotensin II group, much higher incidence of preserving blood pressure and achieving a goal blood reduction. You were able to come off vasopressors more quickly with a little bit of a suggestion of a survival benefit. Now, we did a subgroup analysis of the ATHOS-3 trial looking at the 20 patients who just had cardiac surgery, and clearly the angiotensin II group had a higher preservation of blood pressure. We were able to wean off vasopressors faster, and you're able to achieve your target blood pressure more quickly. So we've also used this in thoracoabdominal aneurysm repair. So you need a mean arterial pressure of 90 to be able to avoid spinal cord ischemia, and we've had very favorable results with this. This is the published literature that's out there. There are 42 cases that are reported and a couple of more that are in publication for right now. Now, similarly, who responds to angiotensin II? This study from the Mayo Clinic group, looking at a couple of different centers, they found about as 2/3 of patients responded to angiotensin II, and as you can imagine, they had higher mean arterial pressure, were able to come off pressors, and were actually able to have a survival benefit. Now, interestingly, they also found that renin responsiveness, the higher the systemic renin, the more likely you were to respond to angiotensin II. Now, what are the adjuncts that you can use? Methylene blue has a role. A lot of published studies show a benefit. Better to use it in bolus form rather than infusion form, so this is certainly something that we use. Hydroxycobalamin or vitamin B12, 5 grams IV works well. Steroids, glucocorticoids, no survival benefit. When you add fludrocortisone, there is a survival benefit, but both of them clearly increase blood pressure successfully. Next, vitamin C. So some data to support this, similarly with thiamine. These are low-risk interventions that have some benefit. Now, should you stop ACE inhibitors and ARBs? So it makes sense. In the European guidelines, it's a class 1 recommendation to stop it based upon this systematic review. Now, interestingly, the one recent randomized trial where they actually stopped it did not show a benefit in terms of it. So I think that's an interesting argument. So what did we do? So we tried everything here. We started angiotensin II. We weaned off the phenylephrine and dopamine. We weaned this down successfully. The guy did well, and everything was fine. So before, we used to start with norepi, go to vasopressin, try a bunch of things, and surrender. Now what we do is we use norepi. We go right to vasopressin, get our mean arterial pressure with angiotensin II, and then we try appropriate agents as indicated, and that's essentially our algorithm now. So with that, 43 slides in 7 minutes.
Well, Dr. Chatterjee, I appreciate the history lesson. 40 years ago, we had norepi, epi, vitamins, corticosteroids, but we didn't have your magic bullet. Thank you.
It's true.
So I have a question. Obviously, Fannin Street, 3 different hospitals. It looks like Methodist and St. Luke's are using Ang2 and also have stakeholders in the company too. So my question is, with the limited data that we have, clearly there's case reports of success. Can you tell us about your experience where it was not successful? Has this worked every single time, or?
No, so I would say so we've used this in about 5% of post-cardiotomy cases. We've used it over 110 times. We have somewhere between an 80 to 85% success rate with it. I would say that it's actually more successful in LVADs and ECMO than some of your standard, some other cases. The big difference with angiotensin II is cost considerations. So 24 hours of epinephrine at our hospital is $30. Vasopressin is $400. Angiotensin II is $1,400. So you have to be rational, and that's why we set up initially a committee. Our threshold of initiation is 0.3 norepinephrine equivalents. Around the country, some people are at 0.2, some people are at 0.4, 0.5. I think you have to come to approach. The pharmacists are reasonable as gatekeepers for this. But, we've come from the problem used to be, we'd finally see this in the ICU 6, 8, 12 hours later. Now the anesthesiologists up front realize that if you don't get there quickly, we can escalate to angiotensin II. In our practice, it is the last drug on, but the first drug off.
Very nice. Thank you.
Thank you. There's some more questions from the audience.
Daniel Becker, Brussels. Nice case. Just one question. How confident can we be it is just a regular post-bypass shock and not a classical anaphylactic shock? Because the severity of hypertension in this patient is quite unusual for post-cardiac bypass. And this patient received fresh frozen plasma, maybe some other drugs that may favor anaphylactic shock. I say this because initially, I was not very happy to see that you use epinephrine, but if it was anaphylactic shock, it would have been indeed the drug of choice, as well as the use of methylene blue and other things like this. So did you make some measurements like tryptase and others to rule out anaphylactic shock?
Right. No, I think it's a very good point. Post-cardiotomy shock can be multifactorial. It can be cardiogenic, it can be hypovolemic, it can be hemorrhagic, and it certainly can be vasoplegic. Obviously, in the operating room, between PA catheter measurements, transesophageal echo, and just looking at the heart, you have an idea of what things are characterized by. And I think it's also remembered, just because one type of shock dominated at time 0 doesn't mean that an hour or 2 or 6 hours later, another form of shock might predominate, and you can always have more than one too. But I would say that, in this sort of setting, a high cardiac output with systemic vasodilatation, this is most classically vasoplegic shock.
Thank you. Great talk. And I think it's a big problem we're facing, not only after conventional cardiac surgery, we see after VADS and after heart transplantation, many patients coming in vasoplegia. Regarding the stop of medication, what's you stop AC inhibitor 2 days, week? Number one. Number two, what's the effect of Merinone? Because many of the patients coming with heart failure are coming on Merinone and Crestor. And last question, is any role for mechanical circulatory support in such kind of case to start to give more support to reduce the requirement for all that high doses of pressors, which might kill the patient?
Excellent point. So one is we stop the ACE inhibitors 48 hours. I think one of the things, just for the sake of time, I think the notion of stopping ACE inhibitors, a lot of these studies came, Argenziano, late 1980s, early 2000s, a couple of studies came out with respect to ACE inhibitors and the association with vasoplegia. And I think in anesthesia, they basically stopped it. So now, for the most part, it's about 48 hours to stop the ACE inhibitors. There's also some relationship with amiodarone in terms of preoperatively. I think milrinone, people who come in on milrinone, by the time they come off, most anesthesiologists try to come off the milrinone. But certainly, when you approach somebody in the ICU, the first things you have to look at for vasoplegia are, what are we doing iatrogenically that can make this worse? Milrinone, propofol, other medications that could be doing that. And I think the other emphasis is acid-base correction and things like that.
My point is to stop them. How you have to stop them earlier, pre-op, because it's a significant problem. And we patient coming to the operating room in Merinone, and we stop 2 days the AC inhibitor, but still facing the problem.
Yeah,
I think that's a
Still
great point.
facing the problem.
Dr. Chatterjee, you have a lot to live up to. I think Dr. Chatterjee, who we knew, would be so proud of the talk you just gave us. I just want you to know, and that's Kanu Chatterjee, who was one of our mentors. I just want to ask you 2 questions. One is mechanistic. Maybe you can leave that for the last. But the practical one is, how confident are you about your volume status in the OR? Because there is now a blood volume analysis, and I'm not part of that company. I have no conflicts. But they are getting into the heart failure market deeply. Hopefully they'll start doing more randomized trials. But this is important. In the OR, you could say, well, we have PA catheters. Well, pressure and volume are completely, as you know, not going to be concordant in some of these patients when there's so much flux. Do you think it would help to say, oh my God, I got 2 liter deficit still? I just given 5 liters in the OR. I have a 2 liter deficit in the blood volume space. Do you think that's going to help? And 2, second question, more mechanistic, maybe we don't have time for this, is how does it propagate? Because I think your observation that if you don't nip it in the bud early, it does propagate. And the question is, do you think there's a mechanism of the endothelium? Is there something that could be in the future worked out mechanistically so you actually say, I know what this is and I'm going to nail it right now?
So thank you. First of all, I appreciate your sincere compliments. With respect to your question, I think the key in intraoperative volume status pressure is you have to correlate the PA catheter measurements with the transesophageal echo findings and then what you just see right there. For example, sometimes you can close the chest and you don't need an echo to know what the hemodynamics are going to do. You've just seen that. So I think you have to correlate each of those in terms of that. I think the other point that's been emphasized throughout the conference is it's not a static one-time shot. It's a dynamic process. You can come off pump at time 0, 15 minutes, 30 minutes, an hour later, things change, and you have to evolve. I think the other thing that you have to take into account is sometimes being cold makes you vasoconstricted, your pressures look better, then you warm up and you vasodilate and things get worse. So I think it's an ongoing thing to be able to characterize that. In terms of that. I missed your second.
Just the mechanism. We can talk later.
Yeah.
Is there some science behind endothelial injury? Something that can help us target things more than just put a huge Band-Aids on it. But the Ang2 data looks, I'm happy you showed that.
Right. I think the best data is that it's very multifactorial in terms of the implications, whether nitric oxide or inflammatory markers, which is why you can't just go with, okay, angiotensin II got me to a satisfactory blood pressure, I'm done. You have to look at things like, we use steroids and fludrocortisone routinely. You have to look at trying to nail other aspects of it to not just treat the blood pressure, but to try to ameliorate the vasoplegic response.
Very good. Thank you very much. Great.